Welcome everyone to Becker's Healthcare Orthopedics plus ASC Virtual Forum. It's no secret that this has been an exceptionally disruptive year in healthcare. While we've been dealing with this pandemic for so many months, a vast number of uncertainties remain around the lasting changes COVID-19 will have on the industry and society as a whole. However, the solidification of telehealth as an essential component of healthcare delivery seems rather certain. For this session, we'll discuss telehealth in orthopedics, including current best practices and the future of virtual care in orthopedics post-pandemic. My name is Brian Zimmerman, and I'm the custom content editor at Becker's Healthcare, and I'll be serving as the moderator for this panel. To begin, I'm going to ask each of our distinguished panelists to introduce themselves and share a bit about their respective organizations. Dr. Cole, why don't you start us off, and then Dr. Bosco, you can go when he's finished.
Thank you, Brian. So I'm Brian Cole, an orthopedic surgeon in Chicago at Rush University Medical Center. I'm the managing partner now of Midwest Orthopedics at Rush. We're a mid to large size private academic practice in Chicago affiliated with Rush University Medical Center. It's a multi-specialty musculoskeletal group. It's been around for more than 35 years. We have enjoyed a wonderful committed group of physicians, not just academically, but professionally and from an innovation and clinical practice point of view. We're very privileged to be in downtown Chicago, situated at Rush University Medical Center. My responsibilities basically are primarily my clinical practice of sports medicine, primarily shoulder, elbow, knee, but I've had the privilege of taking care of several sports teams over the last 15 to 20 years, Chicago Bulls and White Sox and universities, and that's been a great part of my practice. In addition to my responsibilities as managing partner, I'm very involved in our clinical research program, and we've enjoyed years of continuing education for fellowships and residency applicants in orthopedic surgery over the last, as I mentioned, 30 plus years. This year, I've also had the good fortune of serving as the president of the Arthroscopy Association of North America and helping to continue to educate our colleagues in the area of orthopedics and specialty care. So it's a pleasure to be with you today, and thank you for allowing me to participate.
Thank you, Dr. Cole. Really appreciate you being here. Dr. Bosco, why don't you go ahead?
Sure, thanks, Brian. So good morning. I'm Joe Bosco. I'm the Vice Chair for Clinical Affairs at the NYU Langone Department of Orthopedic Surgery. We, like Brian, it's a rather big department. We have 180 orthopedic surgeons centered around a single specialty orthopedic hospital, Langone Orthopedic Hospital. We've been around for about 100 years now, actually 105 years, and continue to grow. We are based out of New York, and personally I do sports medicine, knees and shoulders, and I am currently the president of the American Academy of Orthopedic Surgeons.
Thank you so much, Dr. Bosco, and thank you both for joining us today. And let's dive into these prepared questions. So the first question I have is, how did the pandemic affect your organization's orthopedics program? Dr. Bosco, you want to start us off there?
Is there a pandemic? I wasn't aware. I'm sorry. Yeah. So
must have missed the news today.
You know, we were in New York, and I think a lot of the effect has to do geographically where you're at. But we were in New York, obviously, and we were hard hit in March and April. And I tell people that New Yorkers do what they want to do. They're not very, they don't follow rules. But in New York, we followed the rules because, frankly, you know, we had patients, colleagues that got sick. I got sick. And we had folks that we knew that died. So, you know, my hospital is an orthopedic hospital. We have 90 beds, and it turned into a COVID hospital. So my colleagues and I were on the floors taking care of COVID patients, which is a scary thing. And, you know, like breaking out of Washington manuals. Remember those, Brian, the Washington manuals, you know? PEEP and all this other stuff, and so we were basically taking care of COVID patients. So it sort of scared us straight in New York. You know, we all wear masks and social distance. So basically for 8 weeks we did very little, if no, orthopedics. Our trauma guys had to do trauma. You know, some of our tumor guys had to take care of tumors that needed to be taken care of. But elective orthopedics in terms of joint replacement and sports were basically done for 8 weeks. And then we started to ramp up slowly. So we're in the ramp up process now. You know, rightfully so, some older patients are a little reticent to come into the hospital, have their joint replacement. So but we're about 85% of where we were last year. And hopefully we'll continue to grow.
Good to hear that you're getting back up there. That had to be a tough time. Is the understatement for sure. Dr. Cole, you want to take the same question?
Sure. We were fortunate in that we learned from the tough lessons in New York, and what we all faced was a federal mandate that basically said, look, we're going to stick with essential services and try to minimize or eliminate non-essential, given the demands on protective wear and staff and so forth. And the sole concern was really overwhelming the hospital system. In New York, as you said, got hit hard and fast, and we learned very quickly by the lessons that they taught us. In Illinois, we had a very early restrictive approach, as you probably know, and it made a big difference. Rush also became a COVID hospital. Strokes, they were one of 35 COVID hospitals in the country. I imagine where Dr. Bosco is as well, they were in that same category. It led to the virtual instantaneous elimination of elective procedures, and whether they intended for orthopedics to be considered all elective or not based upon pain and suffering, that was the case. So we were all kind of in the same boat. Some of it, I think, was if you use the logic behind it, we were in a situation where our hospital was filling up, but we weren't beyond, say, 80% capacity. And while we're affiliated with Rush University Medical Center, we actually have peripheral ambulatory surgical centers, 7 to be precise. And most of what we do, I'd say 80%, is actually outpatient, including spine and arthroplasty. So we had different forces, and we're also a private practice group that did not have the backing of a hospital. So like any business, we had to adjust very rapidly. And it was very unnerving. Obviously, our first concern was our own health, our staff's health, and the health of our patients, and trying to figure out how to contain this and at the same time coexist, which is where we are today. So we rapidly sort of mothballed the entire practice. We needed to furlough people immediately. We became an urgent care environment. And we did our best to sort of maintain the business, which, frankly, just to conserve cash so that we had something to emerge into on the other side. Within 4 to 5 weeks, though, we became, it opened up a bit. We ramped back up. We're now in a situation when you combine government loans and the willingness for people to come out and actually seek orthopedic care for any problem. We're, as Dr. Bosco commented, we're about 75 to 85%. There are differences in how people are coming out. The trauma is different. We're not seeing people going out there tearing their ACLs or dislocating their shoulders as frequently. We're seeing different things. I'm seeing a lot more chronic conditions and things that become symptomatic with routine life activities, but not acute traumatic events. Even the traumatologists are seeing a whole different epidemiology of what's coming in. I think we're all now used to living with, not used to it, but we have processes and procedures in place that allow us to live with COVID and function pretty normally at the same time, with proper hygiene, masks, and physical distancing and processes, and have had to navigate that both with professional sports teams, which has an incredible burden of processes, which actually has a lot of relevance to how we actually practice day to day now. So we all feel pretty good about where we are. Obviously, we'd like to be on the other side of this, but I think we're all prepared that the ongoing first wave, it might be with us, unfortunately, until mid-year next year. And I think we're just kind of standing strong and prepared to deal with it and keep the doors open and take care of the patients who need our care.
Thank you, Dr. Cole. And some notable parallels between your two experiences there. And something I want to touch on something with you, Dr. Bosco, that Dr. Cole mentioned, sort of about the types of patients that are coming in. Are you seeing something similar at your organization as well as to the types of patients seeking orthopedic care?
Well, yeah, I think Brian is exactly right. There is some reticence for our patients to come into Manhattan. We have, fortunately, our practice has a lot of satellites outside of Manhattan, and we're seeing those places in Queens and Brooklyn and Staten Island and up in Westchester. There's areas around. Those practices are much more, have come back a lot stronger. People really are a little reticent to come all the way into the city. And frankly, a lot of our patients, I don't want to say have fled the city. That's a little too hyperbolic. But if they have a second home or relatives, they're out of the city, and they're up in the suburbs, because guess what? They don't have to commute to work anymore. They're working from home. So a lot of them are very appreciative and take advantage of our satellite locations. And we are seeing, the patients with minor aches and pains, they're not coming in. We're seeing the more serious injuries and some of the chronic stuff. But as Brian was saying, we do sports. So there's no NCAA sports. There's no high school sports. They shut down the ski mountains at the beginning of March. There's no skier ACLs. So we're not seeing these acute injuries anymore. And it's not that we're waiting around hoping people tear their ACLs or dislocate their shoulders, but that's who we take care of, right? So, we're not seeing that. We're seeing more of the chronic, cartilage stuff that Brian does and we have our folks do. There was a backlog of total joints that we're starting to decompress right now. And as Brian said, there were certain trends that were, and telemedicine's one of them, that were evolving slowly. The shift to outpatient venues for what we do, arthroplasty and spine stuff, distance learning. But the COVID pandemic has accelerated these trends, right? So now patients are asking us if they have to stay in a hospital after a joint replacement. They're asking us if they can do telemedicine. These things are not going to go back. The cat's out of the hay's out of the barn, or the horse is out of the barn, whatever that expression is. So not going back, it's accelerated. So we are seeing a different type of patient, but we're getting used to the new normal, as they say.
Right. And on that telemedicine, telehealth piece, what has your experience been with it? And what role is it playing in your practices now versus maybe pre-pandemic? Dr. Cole, you want to start us off there?
Sure. When we, before the pandemic, we were aware of several technology platforms that offer telemedicine, but the challenge was the reimbursement pathways were not there. And we didn't have, I think we had 2 providers that were doing telemedicine, and they were doing it very strategically. What happened with the pandemic, and within 48 hours, we trained 100 providers on telemedicine. And then we trained 100 physical therapists and occupational therapists. So by the end of the week, when it was like the second week of March, 2.5 weeks into March, everything transitioned other than the most urgent of care coming in the office. And we were very successful at continuing to provide services. I think what paved the way is the technology. A number of technologies, they may have been around, but they made themselves known, as well as reimbursement. We were immediately notified by third-party payers and CMS that there was ample reimbursement that, for the most part, mirrored what office visits were. So when that happened, it opened up the gates to do telemedicine. I think it's sort of at a new equilibrium at this point. Telemedicine is great for potentially everything initially to triage it, but if you look at the efficiencies and what you can get done, it still remains, I think, extraordinarily inefficient for certain patient visits. What we take for granted is when we work in the office setting, we have all of these people around us who can help us with prescriptions and the computer and the documentation and so forth. And at this point, a telemedicine visit takes about a half an hour for a single individual to do, because if you don't have there's no overlap, there's no redundancy. Like when you're seeing patients in the clinic, if you think about it as a clinic room, if you will, it's very different than when you're running 3 or 4 clinic rooms where you're sort of seeing patients very efficiently and you have lots of manpower, people power to help you get things done. So we quickly realized it could be a replacement, a sort of stopgap, but I would not say that it's a permanent replacement for the entire office setting, because the efficiencies are not there. Look, I've often said that most office visits are unnecessary. It's amazing how patients will drive hours, sometimes fly to see us. They wait an hour in the reception area. They see us for 5 to 8 minutes, which is sometimes all it really requires based upon certain problems. And then they reverse the process and go back to work or fly back home and what have you. And it just took them half a day for an 8-minute visit that even the physical exam may have had a negligible contribution to what they needed. And what you also realize is that most patients need education and reassurance, and not necessarily medical care. Even 25 years in practice, 85% of what I do is non-surgical care. So there is an absolute role and place for this from an efficiency point of view. And now the appetite for patients to do this, I think patients have this perception that they have to see the doctor. And it was something therapeutic in and of itself to have a physical interaction with the patient. But I think now they recognize that that's not the case in many instances. So we're now at a new steady state where what I do in clinic is I pick certain patients who I know that there's no added benefit to the care or to the patient at that visit to see them in person. Their exam is normal. They're just in the post-op recovery phase. Maybe they're in therapy. It's all about education, return to activities and sport. That can easily be handled by a conversation. So we've streamlined it to the simple things to be placed in telemedicine queue. And then the things that really need hands-on care are staying in the office. If you take a complicated patient, keep it telemedicine, you got to write an MRI, write a physical therapy script, you might need an x-ray. All of that stuff handled by one person is incredibly inefficient. So what I've done now is I have one provider, extended care provider, advanced practitioner, if you will, physician assistant, who every day we have a telemedicine schedule for very specific patients. Some of them are new patients to get triaged. And then the following week, they may come in and say, look, I was screened on telemedicine. They asked me to come in and get an x-ray. Maybe I needed an MRI. Maybe I just needed an injection. We've become very savvy at using telemedicine. I would say that as long as reimbursement exists, we will keep telemedicine as a critical part of our practice, but it clearly can't replace it because it's not the most efficient. And there are just so many logistical issues in managing patient care that are poorly handled in a telemedicine setting, including the redundancy aspect. So those are my current feelings about telemedicine.
Makes a lot of sense there, and especially when you talk about sort of like the patient perception of telemedicine and their desire to work with that sort of thing, and then also paired with the reimbursement changes, sort of makes sense that it's sort of been ramped up. Dr. Bosco, is your experience similar?
Yes, I think so. You know, and Brian said, Dr. Cole said is exactly right. We look at the efficiency, and initially we'd have these telemedicine visits spaced in the middle of our office hours, which didn't really work very well because you'd be seeing patients, you got 3 or 4 rooms, and you have to sit in front of a computer. It takes 2 or 3 minutes to log on to the computer. Then the patient's fumbling around. You finally get a hold of them. So it's not good to do it in the middle of the office. You should group them at the end of the day. And we've done we've done several studies, and patient satisfaction is high if you do it for the right patient. And my journey, you know, I've been in practice for 30 years, so I'm not an early adopter with anything. But I would sit in the room with Michael A. Brian knows him very well. He's one of my young partners. And, you know, he was doing telemedicine before the pandemic. And I'm like, I should try that. I had trouble logging on, and it didn't work for me. It was glitchy. And that was it. I totally exited. I'm not doing this anymore. So what happened is that with the pandemic, we were forced to use it. And we were forced to figure out how to use it. And we were forced to learn these systems. And you know what? For certain patients, I have 2 stories. One guy, I was an ex-paratrooper riding his motorcycle, and, you know, he fell and had a swollen knee. So, you know, we got a telemedicine visit. He showed me his knee was swollen. I got an MRI without seeing him. The MRI said he had a complete MCL tear. ACL was okay. Got him a brace, wore the brace, you know, checked up with him in 4 weeks. I'd never seen the guy in person, but he's happy because you know how hard it is for a patient to come into the office with a banged up knee like that? That's swollen and painful. It's painful. We had to come in. I would have examined him. I would have sent him for an MRI, and, you know, the same thing would have happened. So this is he's happy. I'm happy. He didn't have to come in. And then my favorite story is a workers' comp patient, Brian, and he actually went back to work, which is a case report. And he's a bulldozer operator. So he's checking in. You have to check in with him every month or 2. So it's like I'm checking in with him now. He's a year out, and I'm talking to him on the phone. I go, "Are you operating a bulldozer while you're talking to me?" You say, "What?" So this guy was actually doing the things with the bulldozer, the backhoe, when he was speaking to me on the phone for his visit. I'm like, that's a little bit. I hate to be on the other end of that thing, but that patient didn't have to miss a day from work to see me, right? So he was happy. I just don't know how safe it is for him. So whatever. You don't want an airline pilot doing a telemedicine visit while he's flying a plane, that's for sure.
Definitely not. I appreciate you sharing both of you sharing your perspectives there. And I'm wondering if, like, you know, Dr. Cole, you mentioned really having to get 100 staff up to speed on the platform. Dr. Bosco, you mentioned sort of some people having struggles, it's not working for them. And it does sound like there's some inefficiencies that are inherent in telehealth. So I'm wondering if there's any other barriers you encountered when you're, you know, trying to scale this thing, get everyone up to speed, and how you work to overcome those barriers. Dr. Cole, you want to start us off there?
Yeah, I think we quickly, just like Joe pointed out, we very quickly realized that doing it in the middle of clinic is not a good idea. You can't, just because of the variability. You know, really the patients, when you think about it, the patient comes and they're at our behest. They come and they sit in a room. waiting for us to come in. It's very inconvenient for them. The flip side is when you're trying to do telemedicine and the internet connection and people are not, this spotty connection, it taps out. It can be really frustrating. So the way it works best for us is that we use an advanced practitioner to do the screening, and that doesn't work in every practice. There are certain very profile practices where they say, well, look, I can never use an advanced practitioner for this, but we have used it, and it allows patients to get immediate access, and the satisfaction rate has been just incredibly high. So the way that, as I mentioned, we started, people would just sit at the counter. There would be a patient coming in a room, and then the other room to keep people out of the office, which is why we use telemedicine now. We've reduced our clinic flow by 30% for everyone. So we said, look, as we emerge back to we emerged back to elective, we said, okay, if you see 60 patients, we're going to chop off 30% of that for each physician, right? So if you have 60 patients a day, we say, let's chop off 30% and push those over to telemedicine. And this is what you get for your clinic space on your clinic days. And we needed to do that for physical distancing purposes. We only have so much space in the reception area. So that's how we're using it now, to allow physicians to continue to practice, but not put patients, make them uncomfortable or put them at risk. I think you need to keep in mind that we've learned that healthcare professionals are not necessarily getting sick now since we've taken precautions. So even when healthcare professionals are working around known COVID positive patients, if both are wearing a mask and you're dealing with hygiene and so forth, and the understanding that we don't stay within 6 feet for any prolonged period of time, and constant hand washing and surface and everything else, we're actually doing really well. And the number of residents and physicians who got sick once we started adopting those things was very, very low. So we actually know that we can do this safely, but we still have capacity or density issues, and everyone's got that. We went from, well, let's have a big reception area, let's keep people in their cars, we'll call them to come in. And the telemedicine has allowed us to effectively offload those who are best suited for it. And now what we do is I actually have a physician assistant who does it from home. So this individual doesn't even come to work that day, he or she can only do 15 to 18 a day. That's it. It may sound like a lot, but it is exhausting to do 15 to 18 telemedicines a day. And you got to cue them properly so that they can actually not get burned out. They can deliver what the patient wants and that they're appropriate. And our central scheduling now is that we've learned over time. I have scripts for everything in terms of who the proper patient is for telemedicine, who just please don't waste their time, get them into the office if you can. But it is amazing, like he gave that example of the MCL sprain. There's a lot of things we really never have to see. They could come in, get their MRI, go home, email or other, let us know that they got the MRI done, and the entire thing can be managed remotely. And I think now that people have an appetite to stay home, this resonates with patients. It didn't before, but now it does. So I think that everything is aligned now from the patient's perspective, the business modeling, and the physician's perspective, and we're all going to gravitate towards this. Is again, as long as reimbursement exists. If reimbursement goes away, this whole thing's going to fall apart. I think the other factor is that we all have to keep our eyes on, like anything, when the bar gets lower, there's a risk of abusing this. And we probably have to really police this, because I don't want it to go away because it ends up that third-party carriers think it's an abuse of the system, because it is pretty easy to hop on a phone call as an alternative, but it isn't efficient economically, quite frankly. You're still better off with throughput issues going to the office, but it is the right thing to do to decompress the office, get proper density, and just from efficiency, people don't have to leave work. They don't have to leave their kids who are doing homeschooling. I mean, you can just get a whole lot done like we're doing today. And when we're done with this, our webinar, we're going to have the rest of our day, and we miss no time. So that being said, we're also missing a big part of the fabric of our society, which is the one-on-one contact. So I don't want to ever take that for granted.
Yeah, for sure. I mean, it's a super easy commute this morning, but it's definitely different. Like I moderate these panels in person, and I kind of miss that for sure. Dr. Bosco, going back to building off of Dr. Cole's comments, how are you working to sort of improve the efficiency of this technology?
Well, what Brian said is exactly true. We use our advanced practitioners or our physician's assistants or nurse practitioners to sort of stack these calls up, because frankly, there's nothing worse or less satisfying for the patient and physician. For a patient, we use the word schlep in New York, to come in, cross 3 bridges, spend $1,000 in tolls to see you, for you to say 5 minutes later, okay, take some anti-inflammatories, do some PT. That can all be done over the phone or by telehealth, and everyone's happier for it. So there definitely is that triaging that has to go on. And initially we were concerned about the about the in-person, the touch, the intimacy, of meeting people. But with telehealth, on the visual, you can do that, and if you do it correctly, then patients feel very comfortable. And I think there's another factor for the adoption of telehealth that I haven't mentioned. I think is important, and that's the regulatory burden. Basically, the federal government, with a stroke of a pen, got rid of all the regulatory burden that was impeding the use of telehealth. And by that I meant, well, initially the patient they couldn't be at home. They had to be in a physician's office or a hospital for you to do telehealth and charge for it. You couldn't, and Brian's got a national practice. I have a practice that encompasses a bunch of states. You couldn't do telehealth in a different state. So if Brian had a patient from Chicago's in Illinois, right? Illinois. So Indiana, now those I-states are all the same. So if he had a patient in Indiana or Michigan, which is pretty close by, he couldn't do a telehealth visit for it because he was not licensed in that state. But now those regulatory burdens have really gone away. And recently, I think they relaxed them on a permanent basis. So I think and frankly, and what Brian said is true about the potential for abuse, because right now, I could just call a patient of mine and do a FaceTime on my iPhone. And then if I have their MRI on this TV on my computer screen, I could do the reverse and they could see their MRI, I could point things out. So you don't have to use a platform. You could use an iPhone and FaceTime and still charge. You can't use a third party like platform like TikTok or something like that. That's illegal. But you can do all these, so it can't be any easier for folks. So
yeah.
You're always talking about, well, you call the patient back, it's been 5 minutes talking about their MRI, their test results, and orthopedic surgeons never built for that. But now you can, because you don't have, even for telehealth, it doesn't have to even be video anymore. It can just be pure audio.
Yeah, the other area, I don't know, I'm curious, Joe, if you've had this experience, but we have 9 physical therapy centers. Yes. And we moved to tele-PT and tele-OT. Now, I can't vouch for how effective it is in every instance, but it kept, we had a lot of patients who had surgery in February, March before the transition and then couldn't get their physical therapy. So we were at least able to prevent some of the adverse consequences of immobility and so forth with a home program. So, so I think that's another area that has to be talked about because PT can be done off-site effectively. And there are now new technology platforms that allow PTs to treat more than one patient in series and so forth. Again, PT suffers from the same thing, the inefficiencies of telemedicine, but there's some really novel platforms and technology now that allow them to do the same thing effectively, but potentially with more than one patient as they're going through exercise regimens and so forth as they video them. So there's a lot more than just the office evaluation of a patient. Oh, I'll tell you one other thing we're doing. We stopped doing post-op visits. I switched to a dressing that is a clear dressing for the subcuticular closure that is like a Steri-Strip, and it's called band grip. You just put it over the incision, and at a week they take it off. We give them Steri-Strips to go home with. So I'm no longer doing post-op visits other than telemedicine. So we call them at day 8 to 10. We call them the next day. Then we call them day 8 to 10. We work through taking the dressing down and switching the band grip dressing. They take that off and they just put Steri-Strips on, and they don't come in the office for suture removal anymore. Right. I only have patients come in post-op who need an x-ray that would make a difference in my clinical decision-making. A lot of x-rays we do for documentation purposes post-operatively, but it never leads to any clinical change. So we might even wait on those. So we're going back and forth now. I'll have telemedicine visit post-op visit 1, in-person visit post-op 2, telemedicine visit 3, and many patients never need to be seen again. So we've become much more streamlined and not wasting people's time to come into the office for like a well baby check. I mean, we become very sensitive to how important or cherished the face-to-face visit really should be. And every visit I have now, I actually say, could this be telemedicine? Does this patient really need to be here? And our filters are much more refined now in that regard.
Right. And I will add one thing is that what Brian is saying is exactly true. And by the way, that post-op patient that comes in at a week for you to look at their wound, say it's fine, it's just not that patient. I mean, there has to be a spouse or a partner or someone that brings that patient in because they can't drive. So now you have 2 people that are inconvenienced. One, you have another person that's didn't have surgery, has to miss a day of work to bring their child or spouse or friend in. So you are really, impacting a lot of folks. And by the way, that person brings that patient in, they can't stay in the waiting room anymore because you don't have room in the waiting room. So telemedicine really is going to revolutionize how we do things.
Some really fascinating comments there from both of you. And we're pushing up on time here, so I want to make sure I give you each a chance to leave our attendees today with one or two quick takeaways on what you think about the future of telehealth and orthopedics. Dr. Bosco, we can start with you, and then Dr. Cole, you can take us home.
Sure. Well, I think, as I said before, we have been evolving towards using telehealth more and more, but the pandemic has accelerated evolution. It's been a disruptor, and so it's here to stay. And as long as the regulatory restrictions stay relaxed, which appears they are, as long as we can make a living using telehealth, it's going to be part of what we do because patients like it, we like it, and it also expands our ability because there aren't enough orthopedic surgeons for everyone in this country. There are not enough pediatric orthopedic surgeons. So for these specialties, it expands their catchment area. So there's increased access to specialists with telehealth if done correct. So it's not going anywhere. It will never replace, we don't think, the one-on-one intimacy from meeting patients, but it does, if used correctly, there's a lot of very high patient and provider satisfaction.
Yeah, I would.
Thank you, Dr. Bosco.
I would take the segue about the patient visit, which has become better. My office is the best it's been that I can remember in my career because I feel less time pressure. And it's interesting. When this was taken away from us, in other words, when the face-to-face interaction, the ability to practice medicine was abruptly taken away from us. I think most of us have never had that happen. And it really gets you back to your roots of why we went into medicine. You know, we're talking about technology and business and everything else. The bottom line is if you ask virtually any physician why they do what they do it because it's part of their fabric. They like to take care of people and they'll do it at any cost, quite frankly. And the challenge is when that was taken away, a big vacuum for most of us occurred. And I recognize now that because my office is less dense, I still run behind, but I run behind for different reasons. Not because I have so many people in the office, because I'm spending a lot more time getting to know my patients. It's partly self-serving to the extent that when I didn't have that, I realized how much was missing, quite frankly, emotionally and intellectually. And so I would say that the satisfaction of being a physician for me right now is higher than it's ever been. And I'm not trying to get, excessively philosophical here, but when something in anything in life, when it's taken away from you, you don't know it till it's gone. And then getting back in the office and getting back in the operating room, I'll never take what I do I think I don't take it for granted, but I will tell you that it's hard not to when you do it to a certain extent, when you do something every single day, the way we do it. I would tell you, I appreciate more now than ever being a physician and having the psychosocial interaction with a patient, which, and I looked at even my own satisfaction scores with my patients who do something we do, like everyone does, these Press Ganey and so forth. My numbers were always good, but they've gone up another 5 to 8%. Because patient perception is just better. They just feel better in the office because the interaction is better. It's not just about their problem. It's about how they're dealing with this pandemic and getting inside it's made the relationship with the patient much more well-rounded. And I think that's important because these are not patients who just have knee pain. These are people who are living a life of a lot of stress right now, like all of us, and they really appreciate the connection. So that's been a hidden blessing. Taking something away, getting it back, learning to really appreciate what we have, and then having an environment that we can actually do it better than we did before.
Yeah. Let me just add that, just to add what Brian said, I didn't operate for 6 weeks. And I thought, when's the last time I didn't operate for 6 weeks? I'd never. Yeah. Maybe we take 2 weeks off for vacation or a week off, but 6 weeks in the OR, it was bad, And I have teenagers, so they're really good at social distancing. They've been doing it for 5 years, pre-pandemic. there was nowhere, you enjoy your patients. You have a better, more appreciation for them.
Well, Dr. Bosco, Dr. Cole, thank you so much for joining us today and sharing your insights with our attendees. And to everyone in attendance, we appreciate you engaging with us, and we hope you enjoy the rest of the event and continue to come back to Becker's for future virtual forums. Thank you, everyone. Have a good day.
Thanks. Bye, Brian. Bye, Brian.
Be safe, everyone.